real common archetype or profile to an insomnia that I see is the overthinker, is what I call it, where that worry and anxiety can create a huge barrier to sleep.
This is Shadow Me Next with Dr. Benjamin Long.
A slight tangent, there's so many conversations around AI and concerns about it overtaking our jobs, but in that moment, that's something that AI is not going to be able to do. Yes. There is something to the human component of accompanying people in their illness experience that great. If AI can diagnose better than me, yes, like we want that. That is a good thing. But we'll always need people who are going to be able to bear witness to suffering and accompany people through that as well. And that's how I view my time in the clinic with my families, is they are on a journey through the sleepless night, and I am accompanying them through that. And it's just a matter of, tell me your story. What tools do I have that can help you along your journey? And let's continue to see where that leads. And yeah, that's a typical day in the sleep clinic for me.
I love that. I can only imagine the frustration that a lot of your patients feel. And I do want to ask in a second, sometimes how that frustration might manifest in clinic as well. But before we get there, there's a question that I'm very interested in. And that is, it ties back to what you mentioned with theology, and you've used phrases like bearing witness to suffering, things like that are very difficult things to walk through as a physician, as a clinician, right? However, you have a really good support system, but many people, they'll lie awake at night because of a million things. Maybe not caffeine in kids, but caffeine in adults or screen time. But from your perspective, how often is insomnia, and you mentioned this a little bit with behavioral, how often is insomnia an emotional or a spiritual signal rather than an actual sleep disorder? Does that make sense? Does that question make sense?
Yeah, absolutely. And the more I've gone on a journey of thinking, how can I integrate theology and medicine and how I practice and how I care for my patients? I really do see those things as aspects of the same thing. When we're talking about mind, psyche, emotions, spirit, in a way, we're really describing all the same thing. Not to get too philosophical too quickly, but too often we talk about the neuroanatomy correlates of behaviors and emotions and things like that. And that is very important. If someone has an overactive amygdala, then obviously that is going to play out in a very different way from someone who doesn't have those things. But you can lead yourself into what's called the fallacy of misplaced concreteness, which is where you assume that the brain scan, that physical thing is the same thing as that emotional experience. And those aren't the two same things, because if you think about it in some way, we still don't even have like a physical explanation for consciousness or a physical explanation for dreams and memories. Yes, a neurosurgeon could probe your brain to, spark some memory, but they're never going to be able to spark the exact same memory and duplicate that amongst people. That's crazy. That's crazy, So that's why there are these mysteries still within medicine that, yes, we have amazing, powerful tools to be able to help us to treat and accompany our patients. But as I progressed through my medical education, I've realized there's something else that was missing. And like I said, all of us are operating out of some kind of worldview. And whether you like it or not, you are operating out of some kind of theology. For people who aren't familiar, theology is just the study of God and God's relationship to creation. And so if I believe that there is no God, I am operating out of a theology that there is no God. And that's going to extend to my patients as well. And so back to your question on insomnia and kind of those barriers, I would say that is very common. The reason why the first line treatment for insomnia, the one that we come back to that we know has the best evidence behind it, is cognitive behavioral therapy for insomnia. It's down to your thoughts and your behaviors and how those become barriers to good sleep. And so that's why in my practice, not only do I get a social history for people, but I also do a spiritual history, which is
Mm.
very simple. I just ask, is spirituality or religion an important part of your daily life? If my patient says no, nope. And then we continue and we have the same kind of conversation that we would normally have. But if you would ask me, what is the one question that changes the whole conversation? I would say it's that one,
Mm.
because sometimes people say yes and we go in a totally different direction. And it always influences the conversation because in one way I feel like I do have a fuller vision of my patient and understanding who they are, but in another way sometimes it really is the thing that is interrupting their sleep.
Mm.
Some people can't help it when they're having a faith existential crisis, or unfortunately when they have experienced real religious hurt or church
Yeah.
hurt, or to the extent of religious trauma of those things. And that being in a medical space, it's not always, I think patients often feel like this isn't the place to necessarily talk about that
Hmm.
per se. Um, and so by me asking that question, I open that door and they know that they are safe to present that side of themselves. In the same way, it's funny because as your pre-med students get into medical school, we will ask a full sexual history. We will ask how you do it, where do things go, how often, and like go down that list and not blush. But then it's so funny when I talk to colleagues sometimes and I talk about a spiritual history, and then all of a sudden they're like, "Oh, that might make people uncomfortable," and I'm like, "Really?" Like, like, oh, okay. So it is this really odd, interesting thing,
Yeah.
but it definitely can, when it does inform the situation and the sleep problem, then it kind of gives you the keys to have that conversation. Versus if you're not even asking the question, then you might be shooting yourself in the foot a little bit.
It's such an interesting take. And one, I mean, God, worked in medicine for how long, never considered. All of it is extremely private, and every
Hmm.
conversation could be viewed as being highly uncomfortable, right?
Yeah.
So to
Yep.
think of one as being extremely normal and the other one is being totally off limits is just, oh my gosh, it's just so interesting. This one, so talking about disordered sleep,
Hmm.
obviously there's a million different definitions of disordered sleep, right? Difficulty falling asleep, difficulty staying asleep, difficulty waking up, things like that.
Hmm.
But let's talk a little bit about the emotions of that. You mentioned mothers sitting there sobbing, crying just because they don't know what to do. There's a lot of emotion when it comes to sleep. Describe for us some of the emotions that play into these sleep disorders that you're dealing with on a daily basis, some that maybe cause the disordered sleep or perhaps might stem from disordered sleep.
Yeah. I'd say a real common archetype or profile to an insomnia that I see is the overthinker, is what I call
Mm.
it, where that worry and anxiety can create a huge barrier to sleep. And so, especially, I'm sure you have a lot of listeners who they're worrying about their finals, they're worrying about their
Mm-hmm.
applications, they're worrying about their job shadowing, they're worrying about all these kind of things. And that is what's kind of like playing in the night. So, as far as just common, that would definitely be a big one.
Mm-hmm.
And, sleep is this unfortunate vicious cycle in a way where
Mm-hmm.
when you have sleep deprivation, going back to those brain imaging studies, your prefrontal cortex that is having like less functioning, and so that's your ability to plan, your attention,
Mm-hmm.
all of those kind of things from the top side, and then your basal ganglia, so then parts of the brain that are more of the emotions like the amygdala and stuff of that nature, those are going higher. And so it's kind of like what we are, the part of our brain that is supposed to kind of help us get through our normal daily lives and a lot of our cognitive functions, that's going down, our emotions are going up. And so then that's why you get more of the, I'm, I just feel like I'm all over the place. I'm moody, I'm
Mm-hmm.
impulsive, or things of that nature when you're getting poor sleep. And so often when you're experiencing that, then you're worrying more, and that can kind of get you into this vicious cycle that can be hard to break.
And if you're listening and you're thinking, oh my goodness, I'm turning my brain upside down. This is me. I need help here. I would highly recommend you check out Dr. Long's book. It's called Sleep Habits Journal, Practices, Prayers, and Devotions to Ease Your Sleepless Nights. This book is incredible. It blends biblical reflections, which I would imagine is great even for people who would not call themselves Christian, right? Or followers of the Bible. Guided prayers, journaling prompts with tools that are proven from sleep medicine to help you calm your anxious heart and invite the Lord's presence into restless nights. It just sounds incredible. Furthermore, the cover of this book is gorgeous. You guys, please check it out. Before we wrap up, Dr. Long, I do want to ask, what is one simple, practical thing that our listener can begin to do right now to help experience better rest aside from buying your book?
Yeah. Yeah, of course. I would say for that, kind of overactive mind, overthinker, one thing that it doesn't sound like it should work is actually scheduling worry time. Which that sounds totally counterintuitive. You're like, why you want me to worry on purpose? And it's like, what I'm trying to get you to do is to form yourself into a person that you are limiting the time that you are allowing yourself to worry. So it's not magic. Everyone always wants immediate magic results. Any behavioral intervention that I give to someone, I say, give this a full try for at least 4 to 6 weeks. Where you're actually practicing it every day. If you come back and you say life got in the way and you weren't able to practice consistently, that's fine. But we can't say that this behavioral intervention doesn't work until we've actually given it a good try. And so if scheduling worry time is exactly what it sounds like, I'm going to have a time outside of my bedroom. So I'm not in my bedroom. I'm not associating that as a place where I'm going to worry. I'm going to do it before bedtime. And I literally sit down and I just write out all of my worries. You're going to notice a little bit of a, kind of bell curve there. And so a lot of patients come back on the second or third interview and they're like, Dr. Long, I am worrying more. So that's part of my advice first is, okay, you will notice an uptick because now you're actually giving your time space to worry. So your mind is going to give you all of those things to worry about. And if you continue to practice it, eventually you will find out you are going to, reach the limit of the things that you've worried about. And that's why I tell people to write it down, because then you can go back to, oh yeah, this is, I'm thinking about this, but that actually is connected to this thing up here too. And so, and then where this actually really helps for bedtime is then if I'm outside of my worry time, I'm going to tell myself, I don't have to think about this now. I'll think about it at worry time.
I love
and that does two things is one, it's, limiting yourself to have just that one point in the day so that the rest of the day you don't have to worry about that. But then two, I tell my patients, if it is really that important, you will remember it at worry time. Because you can get into a worry where you're like, well, I'm worried, I'm going to forget what I was worrying about. And that's like, no, that we got to stop that. And so that's why I tell people if if it really is important, it will show back up at your worry time. And then you can allow that worry to just go away if you can't remember it later. That's fine. It's not going to blow up and be the end of the world kind of a thing. And so, yes, 1 or 2 days, you're still going to worry. Your sleep is not going to be that much different. But if you start today and you do that for like a full month, then when you come back, you can be like, wow, I not only have I like put all my worries down, now I can kind of use my worry time to start addressing some of those worries too. And I can start, maybe challenging some of them or making some plans on how I can kind of mitigate some of those things. And so it just really turns it on its head.
It's incredible advice, Dr. Long. Thank you so much. Guys, definitely check out Dr. Long on Instagram and TikTok, The Wholehearted MD, and find him online at thewholeheartedmd.com, as well as his book, sleephabitsjournal.com. Dr. Long, it has been an incredible conversation. Thank you so much for joining us.
Yeah, of course. Thank you for having me on.